Well, I cannot begin to tell you how pleased I am to have the opportunity to speak to you at this meeting. You've probably grasped that I'm pre-recording, but nonetheless, I've been excited about this ever since I heard from the conference organizers. I think telerehabilitation research and innovation at VA is very exciting, and it is exactly the direction that US healthcare needs to move in this country. So my kudos to all of you for leaning forward on a very important topic. So what I actually want to talk about is why I think this represents a patient-centered approach. We use patient-centered as language all the time, but I do believe that telerehabilitation is really a fabulous, fabulous model of what it means to organize care around the patient. I'm going to tell you a bit about VA research in telerehabilitation and also talk to you a little bit about some of the work that's going on in our innovation space. So I could actually go on for many, many hours. I'm going to be more disciplined than that, but I hope by the end of this that you share some of my excitement for much of the work that's in process at VA. So showing you here a picture of the White River Junction VA Medical Center. Now this is right near Dartmouth, but I want to be very clear, it is actually across the state border in the great state of Vermont. It is not located in the state of New Hampshire. That said, we have a very strong academic affiliation with Dartmouth and one that we're very, very proud of, both in terms of teaching future trainees and having a big imprint on the future healthcare workforce, but also in terms of collaborative research. So I've been thinking about an analogy for telerehabilitation, and the one that popped into my brain was cooking lessons in your own kitchen. So on this slide, I'm showing you, of course, the queen of TV cooking shows, Julia Child. And on one side of her is Ree Drummond, also known as Pioneer Woman, one of the top bloggers in the US by some estimates. And the other person, of course, is Jacques Pepin, who was sort of a mentor to Julia Child. And I understand that they had a show together for a while. Now you watch these people on TV and it all looks awesome. But translating that to your own space, right? They always have more workspace and lots of equipment is a very, very different experience than literally having them watch you cook where you usually prepare meals. That's the difference. And that's how telerehabilitation can actually help patients fit this into their own lives. And in fact, what I have here is a quote from our medical director of human engineering research laboratories saying, "I've personally noted more meaningful information when I can observe a person engaged in mobility related activities of daily living in their natural environment versus what is assessed in a clinical setting." For those of you who are clinicians, this is the difference between asking an individual patient sitting in your office or the same space with you about what they do at home versus literally visiting the home or beaming into the home and seeing what's up with respect to, say, fall hazards or how functionally they are actually able to adapt to the environment that they're in. So for those of you who are not familiar with VA healthcare, we are the nation's largest integrated healthcare system. And very importantly, research and clinical care are fully integrated. More than 60% of our investigators also provide patient care. Let me just say, for any doctors still in training or at early phases of their career, to be a physician investigator, VA is your best bet. That is the end of my recruiting public service announcement. We have had a long-standing partnership with every medical school in the country for the past 75 years. As the number of schools has grown, so has the number of our affiliations. And we're also affiliated with many, many other academic programs in nursing and pharmacy, occupational therapy, physical therapy, and so forth. One of the big reasons I came to VA 7 years ago is that our colleagues are so dedicated to the mission. It's really, really astonishing. And we also have across our entire system what is often referred to as the patient-centered medical home. We refer to that as patient-aligned care teams, but very, very much a care team approach. And this system was actually able to make early investments in and the adoption of telehealth capabilities going back to 2003. Understand, as a federal system, we are not and have not been hemmed in by reimbursement issues. We're more like a globally capitated system, and we weren't actually hemmed in by state licensure restrictions. So this just gives you the raw numbers. I think we can all agree this is a lot of facilities, and we provide care across all 50 states, as well as in some US territories, including Manila, Guam, and Samoa, and so forth. So a very, very large system. Again, we have provided telehealth nationally, initially as a bit of a boutique enterprise, but since the pandemic arrived on our shores, we have seen a 1,785% increase in telehealth visits. And no, that is not actually a typo. Interestingly, I had the experience of a lifetime. In 2014, our New England network had a quality improvement symposium that they'd invited me to speak at. And when I was walking around looking at posters, I came across one from a team of physical therapists at White River Junction. And they had begun recently to provide hip and knee surgery follow-up and physical therapy for veterans in their area. Now, what they didn't know, but I can tell you, is I had several relatives who lived in New Hampshire and Vermont. And New Hampshire and Vermont had had several very, very icy winters. So the very last people you would want out on these icy roads would be people who've recently had hip or knee surgery. So I was really, really thrilled by this. They, in turn, were thrilled by the fact that the real potential hit them when one of their physical therapists had to move. Her husband accepted a job in Arkansas. So she comes to them with tears in her eyes saying, you know, this has been such an incredible experience. I love this team, but we've got to move south. And they said, well, so you can just do it from there. And that's what she did. And I would say, as a nation, we are only beginning to grasp the potential for more and more care being virtual. Right now, TeleRehab at VHA is most commonly used by physical therapy, occupational therapy, and by our traumatic brain injury and polytrauma clinics. Now, this last category is one that is very, very big for us. Those of you who follow this in the medical literature will appreciate that the mortality rate since we went into Iraq and Afghanistan from battlefield injuries has been dramatically lower than any prior war or conflict. This is a tribute to battlefield medicine, but it also means that many veterans come home with multiple comorbidities, including what is sometimes referred to as the so-called invisible wounds of traumatic brain injury, as well as other mental health conditions. So that is a very, very big focus for our system. And in fiscal year 2017, roughly 22,000 of our patients received a telerehabilitation service, and just over half of those patients lived in rural areas. This is a very, very big deal for us because whereas 1 in 5 Americans lives in a rural area, about 1 in 3 of the veterans enrolled in our system live in rural areas. So making sure that we leave no veteran behind is a very big priority for us. And we have seen over time, which is really exciting, this comes from a 2019 survey of veteran enrollees' health and use of healthcare, that more and more of the veterans we serve are increasingly comfortable with telehealth related tasks. From accessing their personal health records, we've had a patient portal in place for quite a few years, communicating with providers, scheduling appointments, filling out forms, signing up for health-related text messages. This has been a very, very big feature in the pandemic, both in terms of directing people where they can park their cars, where it is that they need to enter a facility, as we've begun slowly in some of our facilities to reopen for care, but still want to protect patients and clinicians from being infected. And most recently, in terms of where do you pull in and park and go for your vaccine. So very, very big area for us. And most importantly, joining online support groups. So more and more of our veterans, even though well over half are over the age of 65, are online and definitely willing partners in this enterprise. Our Office of Research and Development has basically got 4 major portfolios, one of which is rehabilitation research and development. There's one focused on health services research, which gets into the challenging questions that I think our entire system is going to be grasping about how do you integrate virtual care and virtual services with the services that are provided in person. There's a biomedical laboratory and research and development service, as well as clinical science and research. So a very, very large enterprise. And when I used to review grants for VA long before I worked here, what I realized is that our budget of over $800 million is probably worth at least twice that, because the clinicians who do the research are actually paid for out of medical care dollars. So in my former life running the Agency for Healthcare Research and Quality, most of a grant's budget was about paying people's salaries. And that portion actually comes out of a different funding source in VA. So the breadth of telerehabilitation research, I think, is pretty phenomenal. From interventions and specific domains that encompass physical, psychological, cognitive, and behavioral therapy, as well as specific clinical problem areas, musculoskeletal, neurological, sensory, and so forth. Probably the strongest evidence base we have in this country is around telemental health. And that has been a very, very important resource for us, particularly during this past year of the pandemic. Rehabilitation research and development advances scientific knowledge and fosters innovations to maximize veterans' functional independence, quality of life, and frankly, their participation in their lives and community. So I'm showing you here some examples of telerehabilitation research, from joint replacement to lower back pain, a very, very common problem among veterans and frankly among many Americans, stroke survivors, and managing tinnitus, or ringing of the ears, a very, very common service-related injury, and really helping older veterans maintain their community living status. I would say VA healthcare has been way ahead of the curve in this last portion, helping veterans live at home. I will tell you, in the wake of the tragedies that we saw in terms of infections and deaths this past year in nursing homes writ large across the country, the proportion of people who report that they would prefer to choose home if that were an option for them and they could get the services they needed has jumped quite dramatically. So in terms of joint replacement, we know that technically we have learned so much, and the technology has improved in terms of total knee arthroplasty, or TKA, and that it results in decreased pain and improved self-reported physical function. However, for many people, physical activity may change only a very modest amount from their preoperative levels. An adjunct telehealth intervention delivered concurrently with TKA rehabilitation is intended to increase physical activity as measured by a daily step count. And it really consists of motivational interview to address behavior change, for example, walking goals. And we're expecting findings in about a year. Now, I want to draw a connection to this between this particular study and the larger phenomenon of virtual coaching. This is an approach that we're using in a number of areas, including helping veterans with chronic diabetes issues manage their own condition and so forth. And if there's one direction that I'm really confident healthcare is going in across this country, it's going to be in coaching, and in particular, virtual coaching. For the diabetes work, it's really interesting because what we have are coach-physician dyads. If you listen to the veterans' reported experiences, the coach is everything. And I think that's something that we will all be learning a lot more about in the now and into the future. Now, lower back pain. We know that cognitive behavioral therapy, there is strong evidence that it can facilitate the management of chronic pain and improves outcomes. And so now we are exploring telehealth delivery of CBT to expand access to therapy. Research has shown by our own researchers that CBT, pain education, and stress management, all provided via telehealth to veterans with chronic low back pain, resulted in similar reductions in pain and disability when delivered by either mental health providers or registered nurses. The cooperative pain education and self-management trial found similar improvements in pain, sleep, and physical function when CBT was delivered using an interactive voice response-based approach versus an in-person therapy for veterans with chronic low back pain. You can see how this just expands the universe, of possibilities in terms of how we can help veterans and organize care around their lives and their needs. Now, stroke survivors, of course, many veterans and other patients have residual deficits following stroke and initial rehabilitation therapy. And we also know that these persistent functional limitations have the potential to improve long after the initial period of rehabilitation is ended and may respond to additional rehabilitation interventions. In fact, I would have to guess that our idea of what a course of rehabilitation is for someone who has suffered from a stroke is not entirely evidence-based. And again, VA, by virtue of how we are funded, is not hemmed in by the usual private sector, at X number of weeks, you're done. So research to evaluate telerehabilitation interventions is looking at the adjunctive exercise and adaptive strategies to improve physical function, adjunct care coordination with veteran and caregivers to address the physical state, falls, depression, and caregiver burden, as well as mechanically assisted upper extremity training. So what this means is that telerehabilitation has expanded the potential to engage veterans and stroke survivors to experience improved outcomes and functional status. As a resident, I had the experience on maybe half a dozen occasions to have admitted the patient to the hospital who was having an acute stroke, when they first presented, and then seeing that individual a year or two later with vastly improved function. And, to me, this was just like seeing God or something. I mean, it was so exciting and gave me enormous hope in both the power of rehabilitation as well as, frankly, in human resiliency. As I mentioned earlier, tinnitus is very, very common experienced by veterans. It is one of our top veteran service-connected disabilities. And the range of how much it interferes with daily life is quite broad. For some people, it is a minimal annoyance, and for others, it actually disrupts daily life. Unfortunately, it can't be cured, but it can be managed to reduce the distress and annoyance that it creates. So in our progressive tinnitus management program, this adjusts levels of therapy to manage progress with tinnitus in intensity and duration. Vast majority of patients only need basic education, and higher levels of rehabilitation for those for whom the annoyance and distress is at a very high level might use sound generators, cognitive behavioral therapy, or guided imagery. It was originally developed, interestingly, for in-person rehab and then successfully tested for remote delivery by video and phone with similar results, including for those with traumatic brain injury. So it's available in both at VA, the Department of Defense, and also the community at large. This comes from Dr. Jim Henry and his team of audiologists at the Portland, Oregon VA. They have a very, very in-depth program on audiology and auditory research, where I had the privilege of spending about a half a day with them several years ago, and it was completely mind-blowing, including the impacts of traumatic brain injury on the ability of some veterans to hear. I mentioned that many, many older people, including older veterans, really want more than anything to maintain their community dwelling status. So research has really been focused on supportive interventions that make living at home possible instead of having to move to an institution of some sort. So the Caregiver Assist program provides video training by occupational therapists for the dyads of the caregiver and the veteran, an older veteran and their informal caregiver for in-home support. I should also just mention briefly, in the wake of, since 9/11, VA has had the opportunity not only to support caregivers in terms of training and technical assistance, but also to provide a stipend for the caregivers of veterans who've had very, very severe injuries. 2 years ago, when we got a new law, we're actually expanding this to all cohorts of veterans. So we don't just recognize the importance of caregivers, we recognize them as part of the fabric surrounding an older veteran living at home. So Caregiver Assist teaches veterans how to safely and skillfully, and when possible, independently perform activities of daily living, such as transfers for toileting, bed, or chairs. And it includes OT recommended provision of assistive devices, grab bars, bed rails, and the like. Think about this. My dad died about 10 years ago because he fell and broke his hip. Now, of course, as a doctor, I had to say, wow, didn't he have any rails at home? Because he had been a little bit unsteady at home. And everyone told me, yes, he had, rails in the bathroom at home, which is where he fell. And that made me feel a little better until I went to stay when he did pass away a few weeks later, and found that what people in my family meant by rails was the rail that holds up the towels, not, and if someone had been actually providing these services or doing an assessment via telehealth, they would have seen that instantly. That's what I mean by provision of assistive devices. So during the pandemic, some principal investigators who were actually focused on rehabilitation research actually modified their protocols to a telerehabilitation format. This represented about 21 studies of all of the studies in the research on rehabilitation portfolio, more than doubling the current TeleRehab projects. And it encompassed both assessment and treatment studies. And depending on when that transition to a teleformat occurred, results will allow us to compare in-person services to virtually provided services, or focus on telerehabilitation only. Really exciting and adaptive response to a pretty unprecedented year with this pandemic. So one enormous asset that VA has is something called the QUERI program. This is the Quality Enhancement Research Initiative. Now, I happen to have been, when I was working and leading ARC, I was on the initial steering group for QUERI going back to 99 or 2000. And at that point in time, it was very focused on clinical conditions. Over time, clinical conditions that were very common, affected a lot of veterans and so forth. And they did good work, don't get me wrong, but over time, this program has evolved to really focus on evidence-based strategies that actually help veterans improve their outcomes far more broadly than what comes under the heading of, say, congestive heart failure. So the QUERI program supports peer-reviewed, national focused implementation and evaluation centered, devoted to the acceleration of research evidence into practice. Remember, the reason we actually have an Office of Research and Development is based on the premise that we will be able to translate those positive findings into the clinical care provided to veterans as rapidly as possible. What's really, really important here is that we harnessed real-world data to shape evidence in practice. So our research routinely harnesses our national electronic medical record data on patients, providers, and facilities to study interventions that improve veteran quality of care and outcomes. Those of you who are familiar with the positive deviance approach, where if you're seeing variability, you compare those with the most outstanding outcomes to those who are not achieving at the other end of the spectrum, to find out what are the people who achieve outstanding outcomes doing. This is far, far easier for us to do than the vast majority of healthcare systems. So the QUERI studies also capture veteran and provider experience data to assess the real world impact, which is everything that our research is about. So there is actually a query with the wonderful acronym of EXTEND, Expanding Expertise Through an E-Health Network Development. Now, this is not a bad acronym, although I don't believe we'll ever catch up to the cardiologists who have the best acronyms in the world. But this particular center is implementing teleneurology and telepain initiatives using quality improvement strategies, which is really, really exciting. Very importantly, it won't surprise you given the high proportion of veterans we have over 65, many of whom have cardiovascular issues, that, you know, telewound program would be a very, very important advance for us. I mean, again, remember that a third of our veterans have to travel some distance to come into our medical systems. So the QUERI Telewound National Partnered Evaluation, in other words, we've got a program that is leading and conducting the actual work of implementing a telewound program. The QUERI team is evaluating lessons learned, who's most likely to benefit, what is the real world impact. So this is a really nice collaboration between our innovation ecosystem and Office of Nursing Services. But the QUERI program keeps us honest in terms of what real world evidence can we harness, and actually evaluating the impact of a virtual wound care program on veteran outcomes. So the QUERI telewound includes, as I said, the VHA Innovation Ecosystem as an internal partner. And the VHA Innovation Ecosystem is kind of a remarkable development over the past 5 years. It actually empowers our frontline employees. Remember, I spoke about dedication to mission, who are constantly thinking of new ways to do things, and oftentimes seeing in their own facilities or environments pretty dramatic improvements in care, which is wonderful. And then the big question is, in a system as big as ours, how do you get that out there? So the innovation ecosystem empowers these employees to facilitate mission-driven healthcare innovation. This diffusion of excellence program really focuses on scaling high priority, high impact healthcare practices across the nation's largest integrated healthcare system. I think this is one of the biggest challenges that US healthcare faces. We are problem solvers. I mean, throughout the pandemic, you've probably all been bombarded by much of the same literature that I have in terms of people finding new ways to do things. But the question is, how do we scale and spread those evidence-based practices? That's what the innovation ecosystem is all about. One example of putting patients first through innovation is the TeleRehab Wheeled Mobility Clinic. So the clinic in real life provides support for the fitting and customization of wheelchairs for veterans in contract nursing homes. We have a number of nursing homes in our own system, but again, given the high proportion of people over age 65, no surprise that we are also paying community nursing homes in some instances to take care of our veterans. So at the Minneapolis VA, which is the nation's largest contract nursing home program, what they are doing is implementing this wheeled mobility clinic as part of telerehabilitation. What this means for the veterans is they don't have to, veterans with complex health needs do not need to travel to a VA facility. And it enables veterans to be seen by a VA therapist and to attend appointments from their current living environment. And very, very importantly, decreases the turnaround time to receive their customized wheelchairs. So what you can see is we've gone from having veterans in community partner locations who lacked access to specialized therapy services right now to where we can connect them with the right kind of expertise at our VA medical centers and or community partners, and they can get an assessment and as well as delivery of the chair without leaving where they live. So I will tell you right now that I'm quite confident in the group of people who are attending this conference and really interested in this topic. There is no shortage of brilliant ideas, particularly those of you who are engaged with research, This is what researchers love to do, right? Is come up with more and better ideas and imagining better possibilities. And in our case, for the veterans we serve, I mean, it does not get any more exciting than that. But it's also very, very important not to forget harnessing the evidence for real world impact and figuring out how do you translate what you learn from a study into real life. How is it that we can make this part of an ongoing program? So I have here a quote from Stephen Sondheim, who said, everything depends on execution. Having just a vision is no solution. So I want to leave all of you with that challenge. Execution has got to be part of your plan, or at least at the back of your brain when you're planning really, really exciting research. This can be hard when you're focusing on something that feels really early and it's not really clear if it's going to work in real life. That's okay. Do not lose sight, even at the earliest phases of research. What would this look like and how would we go about implementing this in real life, and who needs to be part of the team as we think about that? So I want to thank you for the opportunity of joining you today. Many conferences are way better when you have an opportunity to speak with participants, you know, when you're all gathered in the same place. But I must say, as part of the adaptive response of healthcare to the pandemic, virtual conferences are also a fabulous thing to do. And thank you for including me.